My name is Van. I'm one of the developmental fellows, and the title of my project is clinical characteristics and genotypes of a cohort of individuals with neurodevelopmental delays who are nonverbal and minimally verbal, and this is a work in progress. This is my line disclaimer. The information, content, and conclusions are those of the author and should not be construed as the official position or policy of, nor any endorsements be inferred by HRSA, HSS, or the US government. So I'm going to talk about the background a little bit, the study design participants, the methods, and some preliminary results, and then my plans for data analysis. So last year, the American College of Medical Genetics and Genomics published practice guidelines that recommend exome sequencing, genome sequencing as the first or second tier tests for patients with congenital anomalies, developmental delay, and intellectual disability. We know that 30 to 40% of individuals with autism spectrum disorder have minimal spoken language. And language has such a crucial impact on learning, socialization, and independence. Yet there's really limited information on individuals who are nonverbal and minimally verbal, and they're oftentimes excluded from studies as well. So this is a prospective cohort study of nonverbal and minimally verbal individuals with neurodevelopmental delays who have received whole genome sequencing. All patients will be recruited from an ongoing precision genomics study that's evaluating whole genome sequencing in patients with neurodevelopmental delays who are nonverbal and minimally verbal. Inclusion criteria for my aspect of the study is ages 2 years, 6 months to 17 years, 11 months at time of evaluation. And we define nonverbal as having no consistent spoken words, whether it's intelligible or approximations, during standardized tests, across settings, during observations, and according to parent report. And intelligibility is defined based on the Intelligibility and Context Scale, which is a 7-item questionnaire that rates the degree to which a child's speech is understood by different communication partners, including parents, family, extended families, friends, acquaintances, teachers, and strangers. And minimally verbal is defined as having less than 50 words at 30 months of age and older. So during the initial visit, race, ethnicity, medical history, and whole genome sequencing was collected, and we plan to contact all patients to obtain consent for a neurodevelopmental assessment. For the follow-up visit, we propose obtaining a developmental history and then using the following assessments. So for cognitive abilities, we are planning to use the differential ability scale, the communication matrix for communication skills, adaptive behavior assessment system to look at adaptive skills, behavior assessment system for children to look at behavioral characteristics, the social responsiveness scale for social communication, and then the autism diagnostic observation schedule to look at characteristics associated with autism. I wanted to share some preliminary results for the precision genomic study at large, since I do not have any preliminary results for my part of the study yet. So far there are 64 individuals ages 2 to 38 years who have received whole genome sequencing. There are 37 males and 27 females. And of the 64, there are 12 that have had a positive whole genome sequencing. And of those, only 4 have a diagnosis of autism and only 4 have documented neurodevelopmental evaluations. And 36 have variants of unknown significance, and 16 have negative whole genome sequencing. My plans for data analysis is to characterize the cognitive, adaptive, and communication skills and behavioral characteristics for the entire cohort. And then we also plan to evaluate individuals with a known diagnosis of ASD as part of a separate subgroup. We also plan to compare cognitive and adaptive skills between those with a known genetic variant on whole genome sequencing and those without. And we hypothesize that individuals with positive whole genome sequencing are more likely to have delays in cognitive and adaptive skills. And we hypothesize that individuals with more than one genetic variant are more likely to have severe cognitive delays than those with only one variant. I just wanted to thank all of my scholarly oversight committee mentors, Drs. Shankar and Gasteri, Akins, Hagerman, Thurman, and Dr. Thompson, and the MCHB for supporting my fellowship. And I'll take this time to mention that I've also applied for a Children's Miracle Network grant and a Society for Developmental Behavioral Pediatric grant to help fund this project.
So for those of us who aren't as genetics familiar, what are the clinical implications, if any, of what you're looking at?
Yeah, so whole genome sequencing has the ability to maybe identify any syndrome or any variants that can be associated with medical diagnoses or complications that we can screen for. So for example, there were 2 kiddos that had KBG syndrome, which is associated with cardiac anomalies. And so they were referred to get echoes and EKGs. I think Margot is asking, how do we sign up for the study? So all patients will be recruited from Dr. Shankar's cohort. So I can send out that information for how to get connected.
The UC Davis Mind Institute was founded in 1998 with the promise to reduce and prevent the disabilities that can be associated with autism and other neurodevelopmental conditions. Every day, our clinicians and researchers make progress on that promise. Our groundbreaking research on autism, Fragile X syndrome, chromosome 22q11.2 deletion syndrome, ADHD, and other conditions associated with disability are helping affected individuals achieve their fullest potential. Please visit our website or our social media platforms to find out more about current studies, upcoming events, and how you can help make a difference.